All right, let's jump right in. Deep inside our bodies, there's a medical emergency that can strike without any warning at all, and you'd be shocked at how common it is. We're talking about a serious, sudden bleed in the upper digestive tract, and today we're going to unpack what that is and the incredible pills we use to fight it.
300,000. Just let that number sink in. That's how many people are hospitalized for an upper GI bleed in the United States every single year. To give you some perspective, that's more hospitalizations than for congestive heart failure. It's a massive problem.
So what exactly is an upper GI bleed? Well, we're talking about any bleeding that happens in your esophagus, that's your food pipe, your stomach, or that very first part of your small intestine called the duodenum. It's a huge and absolutely critical part of your digestive system.
Now, this is the part that's really sobering. Even with all the incredible advances we've made in medicine, the death rate from one of these bleeds has stubbornly stayed stuck between 10 and 14%. A big reason for that is that these patients are often already really sick with other conditions, which makes a sudden bleed that much more life-threatening.
So that begs the question, right? What is actually causing these dangerous bleeds to happen in the first place? Well, let's line up the usual suspects. At the top of the list, you've got peptic ulcer disease, which is often caused by a nasty bacteria called H. pylori, or from taking a lot of common painkillers like Advil or Aleve. Then there are things like esophageal varices in people with liver disease. But the one we're going to zero in on today is something really specific: stress-related mucosal damage, which happens to the absolute sickest patients in the hospital.
And this slide really highlights the difference. You see, a typical ulcer is usually just one sore spot in one specific area, but stress-related bleeding, that's a whole different beast. It happens in critically ill patients because their bodies are under just unbelievable physical stress, and instead of one spot, it can cause this widespread, shallow damage all over the stomach lining.
So if the stomach's own powerful acid is a huge part of the problem, how in the world do you fight back? Well, that brings us to a class of drugs that were a total game changer. The acid-blocking powerhouses we call proton pump inhibitors, or PPIs for short.
The whole idea here is pretty brilliant. Your stomach acid is amazing at digesting a steak, but it is an absolute enemy to healing. It literally dissolves blood clots as they try to form. So if you can block the acid, you raise the stomach's pH, you make it way less acidic, and you create this calm environment where the body can finally form a stable clot and stop the bleeding.
I love this analogy. Think of it like this. Taking an antacid is like mopping up a spill on the floor. A PPI, on the other hand, doesn't bother with the spill. It goes right to the source. It travels through your blood to the tiny faucets in your stomach lining, these little proton pumps, and it literally turns the faucet off. And it does it irreversibly. It's an incredibly powerful way to just shut down acid production.
Now, because these drugs are so effective, their use goes way beyond just treating a bleed, and this takes us to the most high-stakes environment in the entire hospital, the intensive care unit. This is where these drugs are used not just for treatment, but for prevention.
In the ICU, doctors use a strategy called stress ulcer prophylaxis. It sounds complicated, but the idea is simple. You give these powerful acid-blocking drugs to the sickest patients before a bleed even has a chance to start. You're trying to prevent a catastrophe before it happens.
But here's the thing. You can't just give them to every single person. That would be overkill. So, top-tier medical centers like Vanderbilt have developed really specific, evidence-based rules to figure out exactly which patients are at the highest risk and are the ones who truly need this preventative medicine.
So who are these high-risk folks? We're talking about patients who are on a breathing machine for more than 2 days, or who have something called coagulopathy, which basically means their blood isn't clotting right. Other huge risk factors are things like a traumatic brain injury, a spinal cord injury, or a really severe burn.
This all leads to a pretty logical question, doesn't it? I mean, if the condition is so dangerous and these pills are so good at preventing it, why not just give one to every single patient in the ICU? Just in case.
Well, as it turns out, that just-in-case approach might come with a hidden price tag. And this is where the story gets really interesting, leading to a huge controversy in the medical community about whether we're overusing these powerful drugs.
Okay, so risk number 1. Your stomach acid is actually one of your body's best defenses. It kills off tons of bad bacteria you swallow. When you suppress that acid, you open the door for nasty intestinal infections like C. difficile, also known as C. diff, to take hold.
Risk number 2 follows the same logic. With less acid to keep them in check, bacteria can start to overgrow in the stomach.
From there, it's possible for them to travel up and into the lungs, which raises the risk of getting pneumonia while you're in the hospital.
And then there's risk number 3, something that's come to light more recently. Studies are now showing a troubling connection between starting these PPIs in the hospital and developing new problems with your kidneys, adding yet another serious concern to the list.
And the problem gets even bigger because of how these drugs are used, or misused. This quote gets right to the heart of it. A patient might be put on a PPI in the ICU for a perfectly good reason, but then they get better, they move to a regular hospital floor, and nobody ever stops the medication, even though the original risk is long gone.
So where does all this leave us? Do we just abandon these life-saving drugs? No, of course not. The answer is to get smarter. It's led to a revolution in how we think about this, a move towards a much more targeted, risk-based approach.
The modern game plan is all about precision. First, you use those really strict rules to identify only the patients who are truly at high risk. Then you give them the medication. But, and this part is absolutely crucial, you reevaluate the need for it every single day. And the second those big risk factors are gone, the breathing tube is out, their blood is clotting normally, you stop the drug immediately.
When you boil it all down, the goal is just simple. It's about giving these powerful, life-saving medicines only to the people who really, truly need them, and for only as long as they need them. Not a day more, not a day less.
You know, this whole story is such a perfect example of how medicine is always evolving, always questioning itself, even for things that seem totally routine. It really makes you wonder, doesn't it, what other standard treatments that we all take for granted today might be getting a much closer look tomorrow.